us for our third webinar for the semester. My name is Patience Kamau, and I am here with our grad assistant, Julian Ward. What I will do right now is just briefly go through the short agenda of what you can expect in the next 90 minutes. We will finish at 6 o'clock. I'll give you a brief introduction into Zoom. And I would like to also introduce you to Johonna Turner, who's going to be our host for the evening, and she will introduce our speakers. After she does that, then the speakers will go through the program for the next hour or so, maybe 40 minutes, and then we'll go into a Q&A session where you can submit your questions. We encourage you to submit your questions through the Q&A box at the very bottom of your screen. Please do not use the raise hand feature or the chat box. It's best to use the Q&A box at the very bottom, the dialog box that's labeled Q&A. That way, Johonna will be able to see your questions and read them out. At around 5 minutes to 6, we will have announcements that Julian will go over, and then we will close at around 6 o'clock. Thank you very much for joining us. And just a quick reminder again, when we get to the Q&A session, that we encourage you to use the Q&A dialog box and not the raise hand feature or the chat box. Thank you very much for being with us this evening. And I will hand you over to Johonna Turner. Hi, Johonna.
Hi, Patience. Thank you so much.
You're welcome.
My name is Johonna Turner. I am the co-director of the Zehr Institute for Restorative Justice, and I am especially excited about our webinar today. As Patience mentioned, this is the third webinar in our spring webinar series, the third of 4 webinars in our spring webinar series. One of the things that I most enjoy about our work at the Zehr Institute is when we get to have conversations about restorative justice and its intersection with other sectors of justice, and we're doing just that today. Our webinar today, the topic is Restorative Circles for Health, Restorative Justice as an Approach to Health Justice. And so we get to talk about innovative applications of restorative justice in relation to providing access to healthcare, continuity of treatment in a variety of different ways. And we have 2 guests who are exploring that work in 2 very different ways, and I'm really excited about what they have to share. So I'll introduce them to you. Ivelyse Andino is one of our 2 presenters today. Ivelyse is an Afro-Latina health equity innovator born and raised in the Bronx, New York City. She is the founder and CEO of Radical Health. Radical Health is the first Latina-owned and operated benefit corporation in New York City. And this organization combines her expertise in healthcare and her passion as a community organizer. Ivelyse is committed to the task of transforming healthcare by facilitating health literacy and self-advocacy, as well as forging a relationship between meaningful face-to-face conversations and cutting-edge technology. And one of the things I'll just mention about Ivelyse is that she is an incredibly talented visionary in the work that she's doing. Really, again, her passion for community organizing and healthcare justice, really bringing them together. Really talented visionary and mover in this work. And so I'm just really have just great pleasure in bringing her on as a presenter to share about the work that she's doing. Thank you for being here, Ivelyse. Second presenter, second of our 2 presenters is Jason Walsh, who is a registered nurse and a family nurse practitioner. Jason has worked for 30 years, on adult literacy, neighborhood economic empowerment, post-incarceration reentry, and youth restorative justice diversion. He initiated the Circle of Knowledge program, which promoted and maintained primary and mental health continuity of care for African-American men returning home from prison. He is a graduate of the University of California, San Francisco's Family Nurse Practitioner program, and plans to use restorative principles and community building in the medical field. And one thing I want to say about Jason is he's incredibly creative in the work that he's doing in connecting restorative justice approaches, particularly circles, with the work that he's done both within prisons as well as outside of prisons. And in correctional institutions. I'm really, really excited about also what Jason has to share from his work, his perspectives, and also ideas for ongoing work that he'll be doing at these intersections. Thank you, Jason, for being here.
Thank you.
And so for our conversation today, what we'll do is we'll hear from both Ivelyse and Jason in turn. Each of them will share with us for between 20 and 30 minutes about their work, and then we'll open up to questions and commentary from those of you who are joining us today. So again, Restorative Circles for Health, Restorative Justice as an approach to health justice. Ivelyse, thank you again. Really delighted to hear what the work that you've been doing with Radical Health. I'll pass it to you.
Thank you. I am so happy, excited, and just really honored to be in this space and share my work. I'm going to share my screen. I have a little presentation, and then we can chat from there. Okay, great. So again, I'm Ivelyse Andino, founder and CEO of Radical Health. I'm going to talk a little bit about health equity and how we use circles in our work. I figured that we start a little bit with just, what is health? I don't really know, the audience, how familiar you are, but I think what we do know is that health today is definitely top of mind and the conversation kind of all around, whether it's, single payer access or just some of the injustices we're seeing at reproductive rights. I love to start, with centering and honoring that, this fight against health, equality and inequality has been happening far before I came along. And in fact, Dr. Martin Luther King Jr. in 1966, went to the Medical Commission for Health and Human Rights and said, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And unfortunately, I think the same is true today, and we're still experiencing these inequalities. Today in the US healthcare, we are ranked at almost the bottom. We have some of the worst healthcare outcomes, especially in comparison to other countries and nations. This is, I think, important because we also spend the most money, and especially when you think of first world countries and what's happening, we are pretty abysmal in terms of our healthcare outcomes. What we're looking at here is just a ranking. I don't know if you can see my mouse, but here in the US on the bottom, we're right behind all of these other countries, even given our access to innovation. More so beyond just being one of the worst performing countries in health outcomes, we are also incredibly unjust. When we look at this chart, this is showing the percentage of patients who did not get tests or treatments or follow-up because of costs. Again, these are folks, the yellow are folks who are below average income versus the average income individual. And so what this is saying is that, again, the folks that are at this crossroad, right, who are experiencing some of the worst health outcomes are people who don't have access, who are living in poverty. That will include your folks, most people of color, Black and brown people, immigrants, those that are LGBTQI, people who don't have access. And again, this shouldn't be shocking, but it is when we live and we are in one of the countries. The US spends about $3 trillion annually on emergency care. So we're spending all this money, yet folks who really need the care are not accessing it. The other important piece is that health isn't just numbers. We look a lot at money. We look a lot about mortality rates, so how many people are dying. We'll look at numbers, and we tend to look at health really from this quantitative perspective. And the reality is that for each and every one of us, if you think about yourself, someone you love, your family, health is not just how old you're going to live to or what your, there's a term called A1C levels, right? And that determines your diabetic, whether you're diabetes or not. I guess it's the simple way to think it. But we're not just a number. We're not just our disease or our illness, but we're so much more than that. When we look at health outcomes, only about 80% of our health is determined by other factors, such as where we live, our access to education, even just some of our own behaviors, where 20% of that is just access to care or those moments that are happening inside of a clinical environment. So just to break that down for you, right? Majority of our health is happening outside of the hospital. There's a formal term for this. It's called social determinants of health. And this is really getting a lot of traction now in the health space. But basically what we're saying, right, is our access to where we live, our education, access to food, all of the social, emotional context, whether we're connected with communities, whether or not, where we feel engaged, talk about what's happening, in our government and the current state of things. All of those things impact our clinical health, more so than genetics. So you could have a family history of diabetes, but if you were to move to an area like where I'm from in the South Bronx, you're at a higher risk of having diabetes than if you lived somewhere else. And so this is really important when we begin to talk about the work of radical health and our approach. And so I started Radical Health in 2015. My background was within the health system. And I found the challenge, right, where we were looking at health from a really clinical perspective. We weren't looking at people's whole lives. And I was introduced to the concept of circles and thought, wow, how wonderful would this be if we can actually talk about health in real ways, in ways that, like, the same way I would talk with my aunt or my cousin or my partner and talk about, I really am trying to find a therapist, but I can't, or I found one and that didn't really work out, or, the wait at my doctor's office was too long. And in that experience, I was chatting with a bunch of other people we met at my dining room table and started really to unpack like this idea of what if we could actually do health in community. And so our vision really is that we would have community at the core. This includes circles where we can talk about some of the traumas we've experienced from doctors who may or may not have listened to systems that oppress us with some of the legal legislation. But we really wanted to integrate community at the core with health. And now combining those two things that are often on opposite ends of the spectrum together. And we use technology in our work to really amplify that. So within our circles and within our programming, we chat, but once that's over, there's usually a nice big gap of engagement, right? And sometimes that happens oftentimes face-to-face, but we currently have, we built out an app that would act as like the buffer between the next time we got into circle or the next time we got into another engagement. And it's been incredible. This is one of our circles here. Through our circles and through our workshops, we get to address a few things. One, we get to address and define health. So for many people, and if I asked you all here in the chat or whatever it is to define health, we'd all have incredibly different definitions. For some, it is a clinical, right? I have a pain in my knee and it is killing me and I really want to fix that. For others, it's, living a long, generous life with family and loved ones. And we each have different definitions. And so through circles, we really get to define what health means for us in this moment. It's also important, and we recognize the fact that health is not just a static definition that you define it once and that's what it is, but that our ideas of health and healing really transform depending on the time of day, the month, instances that are happening or occurrences that are happening. And so really giving folks a space to define that has been incredible. We get to build trust. So our circles, we do both in community and we get to do them with providers. We talk a lot about, doctors or a health system. But I think, we don't put the blame on that system because many times folks in those systems are really struggling as well. And so we get to do kind of two things. We get to build trust both in community, but then also with providers and then integrate the two. So we're actually building these meaningful conversations, meaningful relationships that transcend not just our engagements with health, but really build onward and outward. Build community, and that's the bullet there. So what we're doing today, we're in New York City. If you look at where we hold, we have workshops here, but these are our circles. We tend to work in the areas that have the highest rates of poverty, but also the highest rates of incarceration. So in New York City, this upper quadrant here, that's the Bronx. This is Brooklyn, Brownsville, Bed-Stuy, some parts of Manhattan, upper Manhattan. And we layered where we do our work on top of life expectancy. So again, what you can see is your zip code determines how long you will live and your health outcomes. And so if you live in an area like the South Bronx, up here where I am right now, you're likely going to live a lot less than someone, let's say, who lives in Manhattan, on the Upper East Side or Lower Manhattan. And so it's important that for us in radical health, the work that we do, we center that around communities and around communities that have faced incredible injustice to hopefully restore and heal. Our folks love doing these workshops. These are just some of the numbers, but in our circles, right, folks are learning new things, but they're also being supported by one another. In some of our circles, we've had folks who have revealed diagnoses and found someone within that circle who's had a similar diagnosis. And they were able to support each other and connect with one another. They love 97%, would like to attend another circle, and 97% also feel really connected, not just to the fellow attendees, but also those who are keeping, and then some of the other folks who arrange that. So whether that's administration from schools or leadership from hospitals or nonprofits, really feeling the sense of community that, again, transcends beyond the circle. And so in every circle, we end with this, chant, and this is kind of our mantra from Assata Shakur, but really it is our duty to fight for our freedom. It's our duty to win. We must love each other and support each other. We have nothing to lose but our chains. And so, thanks.
Thank you so much, Ivelyse. Wow. That was really, really wonderful to hear about and amazing. And I know that lots of people have questions already. So one thing I just want to do to encourage those of you who are participants is to go ahead and just jot down some questions and comments that you have right now, whether you want to go ahead and put that in the Q&A feature, just jot it down for yourself somewhere. That way, when we come to the Q&A portion, after we hear from Jason, you don't forget those things. But one comment that I want to make before we go to Jason, it was really interesting for me to hear, Ivelyse, how you're both using circle processes as a core practice model, which is core so many models are to our practice in restorative justice more broadly. So you're using that practice, but you're also using restorative justice as a philosophy and a set of principles and values to also as an approach to your work overall in health justice.
I muted myself. Yes, thank you. Yeah.
Thank you. So again, if you have some questions, thoughts, comments, you can jot those down. And now we're going to hear about a different kind of project. So you've heard about Radical Health and their approach to restorative circles for health. And now we're going to hear about a different project that's happened in a different context, a program that Jason Walsh has run. And again, for those who joined us a little bit later, Jason is a registered nurse and a family nurse practitioner. And he initiated a program in a men's prison called Circle of Hope. I think I have that.
Circle
right.
of Knowledge.
Circle of Knowledge. I'm sorry. Thank you, Jason, for correcting me. The Circle of Knowledge program. So we're now going to go to Jason and hear more about that program and his the ways in which his program is similar, also the way that's different, but just overall thinking through how he's using both circles and restorative justice to inform that work. Thank you, Jason.
Yeah, thanks, Johonna. So just thinking, Ivelyse laid out so many of the issues that we've been facing for a long time, and I'm excited. It was nice to hear about approaches and ways in which people are actually coming together to address this, because it is, I think one of the most striking things is really just looking at life expectancy and correlating that to zip code. And I almost feel like the conversation can stop right there, and we can say, all right, we've established injustice. Can we move on and begin to address it? But unfortunately, the scientific model doesn't work like that. We like to really find the variable that causes it, or we believe there's one simple reason. So anyway, there were so many thoughts as you were speaking that I was like, yes, yes. So thank you. In thinking about Circle of Knowledge, that was a program that was, it was a grant funded by the Alameda County Behavioral Health Care Service. So as many of you probably know, our jails and prisons have become our depository for people with mental health issues. And it becomes a crisis. Most people, I mean, it's a crisis, but it impacts communities, and where public health people become aware of it is folks from prison come home, and they're coming home with mental health issues that and traumas that they've experienced in prison and prior to that. And the system for care is to go to the emergency room. And that's just not an efficient way for people to receive care. It's an emergency. It's it's a Band-Aid. They patch you up. They send you back out. So Circle of Knowledge was an attempt to bridge the continuity of care from prison to the community. And ironically, prison is one of the few places in America where you are guaranteed health care. So just to think about that as a statement on our healthcare system. So what I did with the grant was to start a program that was based on Circle process. And I would go into both California Medical Facility and here in California, and in San Quentin State Prison. And I would recruit people to participate in a circle that was designed to help maintain continuity of care and develop a strategy for mental health care if needed on the outside. Now, what was interesting about this, it was targeted towards African-American men. And as you can see, I'm not African-American. So when I go into a prison, prisons are extremely racialized. Our society is, but also prisons are just very racialized. So I wasn't necessarily able to just go and talk to people and bridge the very big gap that existed between me coming from the outside as a white man, talking about mental health, and going into a context where you can't talk about those things openly. And you certainly, it's just difficult to cross racial divides inside prison. Fortunately, there were a couple of men that took a risk on me, and they came to my circle, and very intentionally, it was called Circle of Knowledge because I think the emphasis is on what people know. I'm not an expert. I'm not coming in with the answers. I'm coming in basically with a process that can create a container for a conversation and strategy building. So I think that was part of the success of it. I think the men who did come to the program, most of them were lifers, so they had life sentences. They in turn they would reach out to some of the people who were leaving and basically do advertisement for the program and make suggestions that they should come to this. So I feel like, we have models in other parts of the world where we have healthcare worker models, where people from the community serve as liaisons between the medical institution and the community. And it's a very effective way of bridging the gap. So I think, I'm sorry, I think that I'm jumping ahead, but I think what we can do with this model, thinking about restorative justice, is to address some of the equity and equality issues that we have failed to address from a medical perspective by using restorative processes to have conversations about where the system is failing, so that we can then, and as a provider, I need to know where I'm not meeting the needs of my patients. I think circles are the way to move forward. I think Ivelyse presented a really good strategy and way to do this. And I think what is needed is for practitioners, medical practitioners, to sit in those circles very quietly and not come with diagnoses, not come with prescription, but to come with answers. I mean, questions, I'm sorry. Too often we feel we have a 15-minute visit and we feel that we have to have an answer at the end of that 15 minutes. Usually that answer is a medication. It's not a relationship. So I feel like circles are the opportunity to build those relationships so that medicine can get back into the relational business and not just be about prescription. There is, you know, in thinking about moving from the Circle of Knowledge program into now medicine, there are things called group medical visits where they're an interesting possibility because it's a collective engagement with people who are suffering from the same disease. So if you have hypertension or you have diabetes, people come together for support and work together and have strategies on how to address certain issues. So it really stands as a method that within the medical context that can be infused with restorative justice principles. It can, you know, we don't, in those situations, you're just not talking about nutrition. You're talking about food scarcity, you know? So if, you know, one of the things with diabetes is we're always suggesting, oh, you need to change your lifestyle and eat better. Well, that's not an easy thing if you don't have a grocery store nearby, or what's available to you is going to continue to raise your blood sugar. So what group medical visits can do on a very fundamental level is just build collectivity and resource knowledge around what do you cook at night that's healthy, that will help you manage your diabetes. Where do you get your groceries? I mean, these are some of the fundamental questions that I feel like we can begin to answer that speak to preventative care and not emergency care. These are conversations we should be having in communities, outside of medical institutions, you know, in public spaces, in a way that we can very honestly talk about bigger issues than just individual health. We're talking about systemic issues that impact people's health. You know, there's a term called allostatic load, and that looks at kind of the contextual stress that impacts a person's well-being and health. And we don't have an individual marker or an individual drug that can lower that number, you know, and it's going to take all of us to really to find ways forward to be a healthy community. So I'm looking at my watch. I think I'm pushing up against time.
There's plenty of time if you want to say any more, Jason.
Well, you know, I think, and Ivelyse again spoke to it, the problem when we separate the condition from the context, and we, you know, our medical perspective is to individualize and treat. And by doing that, we separate the person from their context and the factors that impact their health on a daily basis. And that's where group medical visits, that's where restorative justice steps in. It reconnects people to the wellness of the community, and it stops this individualization. I saw this, you know, in prison all the time, where a person may have committed a crime and it was contextual in that situation at that time. But when they're in prison, everything is individualized and they're cut off from community, they're cut off from family. It's, you know, the men that I worked with were no longer partners, they were no longer fathers, they were no longer brothers. They became, you know, criminals who needed rehab. And the fact is, when they were leaving prison, they became all those things again. And they also became a person who may have become HIV positive or had a serious episode of depression. So now they're coming out, but they've been individualized to such an extent that building those bridges back becomes almost impossible. And then you add on top of that some very serious health concerns, and we have a real problem. It's nearly, people who leave prison get 1 month of medication. They get $200, and that's that. So if you are not prepared to maintain your HIV prescription, your high blood pressure prescription, your diabetes prescription, you've got a month. And a lot of people coming out don't even know the names of their medications. They're not given their health charts when they leave. So these are things that collectively we actually can address. The system is not very good at addressing this. And I think it's that individualization that restorative justice really can move us from.
Thank you, Jason. I found so much of what you said, really the whole body of it, so compelling. One of the pieces that you just emphasized is kind of this structural piece. And I think that can often be an element that could easily, go unnoticed in terms of talking about the contributions of a restorative justice approach. I think that you all talked about so many additional elements, how restorative justice, particularly the circle process model, helps to build trust, right? Helps to elicit collective knowledge and also to build relationships. And so it makes so much sense to use that in a place where trust is needed, where there are broken or fragile relationships, and where there's a need for collective knowledge. But you both took that so much deeper in talking about this structural element and how, in addition to those things, really it enables a kind of identification and collective analysis and more dialogue around those systemic root causes. Ivelyse, I don't know if you want to, before we even just take to move out, want to comment on that a little bit, if you'd like.
Yeah, totally. I mean, I think, what we talk about, and I think I talked about, Jason did an incredible job of talking about, just some of the challenges in real life. And I think, one thing is, like, when we talk about trust, right, we're talking a lot about folks who have been abused within the system, right, or coming out of a system, whether they're incarcerated or whether, you go into a health system and we've had these bad experiences. And so we're trying to rebuild that trust. I think one other piece of it, right, is on both ends, right, is a lot of us, especially people of color or, those who have been like historically marginalized, might not even engage with a health system because of trust. So when we look at like the Tuskegee like syphilis experiments, right, where Black men were being like infected intentionally and having research done on them without their consent, or birth control in Puerto Rico where women were being sterilized, and in California as well. I can tell, like, my own family, my own experience, right? There's a lot of hesitation around engaging with any healthcare system, like, and that's a baseline, let alone then all the other compounded issues. So I think, on the front end, I guess you can call it that, right? How do we begin to unpack just some of the historical, cultural, right, pieces that we have and incorporate, I think the beautiful piece about circles themselves and circle practices, embracing the indigenous piece, right? That also healing and health isn't just this clinical, Western clinical thing, right? But that we each bring our indigenous selves to that and honoring that for folks who want to talk about that and having a safe space to do that. And then I would say on the tail end, right, and something that we can be preparing for and as a call to action is, right now, and this is to Jason's point, like, folks are being, traumatized. Again, whether they're in jail or being detained, young kids being sedated right now. What does that do to our collective community health, right? And in perpetuating, right, some of the fear, some of the mistrust, and how do we begin to hold space for that for a whole healing of sorts.
Thanks for that, Ivelyse. One of the questions that I would invite you all to speak on, just adding on to the comments that you've already shared, that's especially interesting for me. I'm interested in hearing more about is, how did you come to this work? Jason, you have a healthcare, both of you have healthcare backgrounds, and I believe you're also a community organizer. And so I'm just wondering if there's a particular aha moment or experiences you've had. I know that you both have also partners who are involved in restorative justice work, but just kind of what experiences led you to really land at the intersections of the work that you're doing and the approaches that you're using?
Yeah, I think for me, I was teaching GED in high school in a jail, and I would see the women that I was working with come in and out, and I felt like there was a Band-Aid approach that wasn't working, and for me, education was always the way. That was the answer, right? It's like, oh, if there's a problem, we need to educate ourselves about it and work our way out of it. And so when I started feeling like that pedagogical approach wasn't working, and it was prescriptive. It was a top-ward down model. And I started to see what it was and my participation in it, and felt like there's got to be another way. And that's when I went to Kay Pranis's training and got circled up, and I was like, this works, and I think it's just been a slow process of moving through interacting with systems. And for me, I'm always kind of working on the periphery and on the edges, trying to see if it's possible to develop a restorative justice methodology within these contexts. People, for me, I'm at the point now, I've moved into as a medical practitioner. I'm like, there are some good things that we have in medicine. There are, we do need health centers. We do need health clinics. Antibiotics do work for certain things. It's like, there is real medicine that works. And I think for me, it's like, don't throw the baby out with the bathwater, but be really clear on what the bathwater is, So that's where I find myself now. I'm learning about the medical system. I'm a new primary care provider, but I'm in the back of my mind, I'm like, okay, how are we going to do this? How are we going to do this? How are we going to change this system to meet the actual needs, as opposed to the, what the insurance companies like to see happen? So.
Thank you. Ivelyse?
Yeah, I love that, Jason. I think, for me, I think it was the same. I love what you said, operating on the fringes. I mean, that's my baseline. But I think I kind of got into this work. I mean, I'm born, I'm raised, I still live in the South Bronx. And if you know anything about the South Bronx, yesterday we were just awarded the 10th consecutive year of having the worst health outcomes in all of New York State. So number 62 out of 62. And it's horrific. And so I've grown up right in this space where, like, this is just normal to have horrific health outcomes. And at a young age, I wanted to be a healer. I wanted to be a doctor. I made my way in like the formal healthcare industry. And my job was actually to run a peer-to-peer training program for large pharmaceutical companies. So I really got to do that and got to see the background of how this machine works. I was working in cancer drugs and how cancer drugs are rolled out, and you train the top physicians in the country and they train others, and really using this model of each one teach one, and how effective, more or less, that was. And so I was running that program. It was incredible. I was super young. and my mom was diagnosed with cancer. And it was this like ironic space of, by day, all these resources, by night, like none. And in that space, like I really questioned myself, questioned who I was, and questioned just the whole process. And so I think that was the beginning of understanding like how a system that I worked for and I failed, and especially Black people, brown people, those with disabilities, so on and so forth. And so that framework kind of stood with me in that question. And then as I began doing like community organizing and understanding community and experiencing circles through my partner's work, I also know that there was a lot of similarities, because then I would encounter individual physicians who, if anyone ever gets into healthcare, it's usually not to be rich, because you could probably work on Wall Street and make some millions, but you really get into healing and medicine to help and to heal. And it reminded me, as I was hearing these stories of med school and residency, and how it really becomes like, I would liken it to Army boot camp, where you're not sleeping, you're being indoctrinated with all these policies, but there's also this very clear hierarchy that relies on racism, sexism, like there are all these things that happen within that system. And so as my partner was doing work in the juvenile justice space and starting to unpack that, and what's happening in courts and the same levels of hierarchy, I was like, well, I wonder if we could apply some of the same principles to health. And I wonder, this actually started with wanting to create a safe space for providers, so that they could organize and unite and heal. We were calling it like healing for healers. And then it became, well, if we're going to do that for providers, then we have to do that in our own communities. And how can we use our power, our people power, our shared experiences to like honor and hold space for one another, but then also really transform this system, but doing it, like Jason said, on the fringes, and doing it in unconventional ways that really build rather than direct.
Thank you, Ivelyse. Thank you. Also, again, Jason, one of the things that was so powerful to me, hearing both of you share your journeys with this work, is the way in which so much of your kind of personal and what we often divide into, right, binaries, personal, professional lives, converge to lead you into this path, this really important path. And also both of you sharing about kind of the margins as a space for innovation and creativity. Such power in that. Thank you so much for sharing those journeys. So we're gonna actually open up now and go into some questions from those of you all joining us for this really, I think, fantastic, important conversation about restorative justice and health justice. Some of you have already contributed questions and comments to the Q&A space. For those of you who have not yet, I just want to invite you to go to the Q&A feature at the bottom of your screen, and you can share a comment, you can share a question that you'd like to have me read aloud or to ask our presenters to answer. If you would like to be anonymous, in that you can, I won't share your name, but otherwise I will share your name so that they also have a sense of who's asking the question. If you also want to share in your question or comment where you're based at in the world or what organization, you can add that and I'll share that live as well. So let me go to our first question. First question is, I have questions for you both. So first question, I'm going to go to Ivelyse. This question is for you. Do the circles that you hold ever focus on building up the participants as advocates for better health policies at the local, state, or national level? So it's especially tapping into your work as a community organizer. Do the circles kind of intersect with community organizing and bringing people into organizing around health policy?
For sure. I will tell you the secret sauce. As we do these circles, we really focus on we call it like hyper local communities, right? So we're doing circles in little areas and regions, right? And my theory behind that was I didn't necessarily want circles to be just health focused, but I really want to build like community and not, I don't want to say build, but I really want to reinforce and pull together people to have these conversations in ways that create movements. So one, yes, like we're organizing not just for any specific cause or policy, right, but organizing just to organize and build. And then two, we do a few things. So we have circle keepers that actually hold circle, and in some of our other workshops, we have like lead facilitators, but we also invite community facilitators into that. So these are folks who have zero experience, who are just members of the community, and we work with them, right, so that they can hold space. We're starting this year to do some other programs, right, that are like circle training so that everyone has access. We really believe that everyone should have access to this and that they can move it forward. But on the policy side, that's a part of our technology, actually. So we built out this app that is a Know Your Rights for Health app, so that you can ask questions. It's a chat-based app, so you can ask questions before you go in for an appointment, or just understand what you are entitled to. So examples of that are, asking for a translator when you go into the emergency room, or even, before a visit. How do we begin to, how do you ask for your blood result or a blood test before a primary care visit? So that you're bringing in a sheet of paper and actually having, questions and real, like, tangible questions. And then other stuff around, the other like legal local laws. So our goal really is to, that this isn't start or end with radical health, but it really is spread out, and that everyone from the community can begin to take their own action wherever they feel comfortable to ultimately change this. Oh, Joanne, I think you're muted.
Thank you. I was saying thank you for that response. And it's really interesting what you're saying about people having the kind of the different levels of participation and advocacy and organizing. And I guess a follow-on question to that is, does Radical Health partner with other community-based organizations that are doing advocacy and organizing for health justice?
So right now, we'd love to partner with others. We have, we're actually doing a conference next week with the Legal Action Center, who are doing health and justice work. So we try our best, to partner with anyone. We typically partner with folks who are not in the health space, surprisingly. And I think that just is where the need is. So folks who are doing housing work, we partner, alongside them because it's just like an easier partnership, I think, sometimes. But we love to partner with other folks who are doing health justice work and support the movement, however, wherever we can.
That's excellent, and it's really cool to hear about the partnerships with other organizations, other kinds of groups like housing. That's really interesting. I'm interested to hear more about that later, perhaps as well. Thank you so much. So this next question is for you, Jason, and the question, I'll share the question and then I'll share a little bit of a background, is what have you learned about people's needs through the circles that you facilitated in prison with incarcerated men that you didn't understand before? So what have you learned about their needs? And then how do you see that information as helping to shift the system? And this question is coming from one of our guests, Kirby, who was surprised to hear that there's uncertainty about the needs that patients have that aren't being met by physicians and by others within the medical care system. There's a sense that people have been giving feedback on their unmet needs, but the system doesn't seem to have an interest in adjusting to meet those needs, which you mentioned when you shared. And so that's a little bit of the background of where that question is coming from as well.
Yeah, I would agree with, I think, the background context that the system is not responsive to people's needs. I think one example I can think of to show you was from a circle I did in the California medical facilities. So it was about 15 men. I would come in generally with a question, just basically, that's kind of the beauty of circles, that a facilitator really just needs to get the ball rolling, and then it goes. And I don't even remember what my question was, But we had a talking piece, and the rule was that the talking piece is whoever holds the piece is the one who holds the floor, and it only gets passed around the circle. It doesn't jump and fly around, and somebody can't go ooh, give me the talking piece. So, you know, I passed the talking piece to the guy left of me, and he would always sit there because he wanted to go first. But he proceeded, you know, we had about 90 minutes for the circle, and he proceeded to talk for 75 minutes. And that, the whole time I'm sitting there as a facilitator and I'm thinking, oh my God, oh my, what do I do? I gotta interrupt this. This is not what's supposed to be happening, right? I have an outline, I have goals to reach. This isn't going to get them any closer to signing up to see the psychologist, blah, blah, blah. When in actuality, my agenda versus the agenda of the group were very different. He finally, you know, closed out, and he just had some heaviness on his heart that he needed to share. And I was just concerned that the whole circle was out the window. But as the talking piece finally started moving around, each and every one of the men in the circle appreciated that, one, as a facilitator, I didn't jump in and stop it, because that went against the values that we had established as a group. But that the need at the moment was for him to speak. And that was the health and the understanding that needed to come out at that moment. And I think far too often in most settings, but particularly in the modern medical setting, I have a patient coming in, I'm looking at some values that, you know, some blood values or some hormone values. I've already constructed an agenda in my mind as to what type of treatment is needed, what list of drugs I'm going to suggest, maybe some follow-up labs and some lifestyle changes. And when the patient sits down, I'm spending most of my time with my computer working through the record. And so even though I think, oh, you really need to get your cholesterol under control, and I want to talk to you about that, they may come in as a patient and want to talk about, you know, the difficulty that they're having sleeping, which is not related necessarily to their cholesterol, you know. So in the circle is listening. And I think that's where the medical field is not responsive to, and not really constructed in a way to pull out what people need. Right? We don't create an environment that is conducive for people, particularly, as Ivelyse pointed out, particularly for people of color. We have a huge underrepresentation of people of color as medical providers. I don't speak Spanish. I have Spanish speaking patients all the time. I am missing so much because of that. I'm cultural cues, the proper way to ask questions, the right words, and translation is helpful. It's great, but it doesn't capture the whole thing. And so these are some of the ways I think that the system could slow down and be more responsive. I hope that helps.
Absolutely. I'm really struck by your story, the story that you shared. One, that's an amazing patience and discipline on your part as a circle keeper, even in other settings. I think it would be quite, for many circle keepers, difficult to hold that to that value after someone has shared for that amount of time. So thank you for that story in that regard as well, just as a really incredible story of effective practice and really what it means to hold to those values and principles in unexpected, right, in ways. But the other thing, Jason, that you shared that was stood out to me is how the disciplines that are cultivated in participating in a circle or keeping a circle are transferable skills into the medical setting. That was really interesting.
Yeah, I think it's really true. I think I think this is where the system change comes in place, is that we have to carve out space to allow those skills to come to the front. And you know, the group medical visits that are being developed, the reason that they're stalled is because it's a question of billing. So how do we bill for a visit, you know? And you know, that shouldn't be our chief concern.
Absolutely. And I think this next comment, in some ways, it dovetails with what you just shared. This comment is from Victoria. Victoria says, I have worked in acute inpatient and emergency department behavioral health. The priority from healthcare companies is medical stabilization. Healthcare professionals and patients want and need more resources on health justice and equity. We as a nation need to focus on the proactive ways in which we can resolve these problems instead of primarily being reactive and medication focused. And both of you spoke to that. I don't know if you have any other comments that you'd like to make about any aspect of that input.
I mean, I just would agree. You know, I've worked for some of those companies that were all about medication adherence. And ultimately, right, what that speaks to is profit. That is the bottom line. And so my call and my ask and my work, I think is twofold. I think as a community member, as a person in the community, and I intentionally just use that word instead of patient, only because it's the root word of patient in Latin means to suffer. And I think when we just look at ourselves as just patients, I think then it becomes that same transaction. So to even break away from that system, my community members, but I think that, you know, as community members, we've been talking about what we want and need, and this is what Jason was talking about previously. The system hasn't really listened or heard or has even the capacity or the space. So I think what we're really looking at right now is how can providers on all spectrums, right, also begin to create new spaces for these conversations. And I think, right, I likened it to like an army or a military of sorts where, you know, there's a rank and file and chain in command, and not everyone does that. And so there are incredible activists out here starting to speak up. But I think we do need some support though from the provider community. And I think like what Jason is doing in his work and you know, challenging even a system at times or offering other solutions, I think is where we'll start to see some of that change, but fully agree with what was shared.
Thank you. Jason, is there any other comment that you'd like to make on that input?
Yeah, I was thinking, you know, as we're thinking about future, that, you know, it's important that we consider the past and that we kind of excavate and look at and understand what has happened that is preceding where we're going. And I think another interesting thing, you know, I'm no longer interacting with patients. I'm now interacting with consumers of health services. And what does that mean? I mean, does that mean you get the help that you can purchase? I mean, that's what we see. So, you know, that's a really, I think is a dangerous place to be for something as important as health, to think that we're going to link it to your ability to purchase it. But that is definitely where the system is taking us. And I think through community involvement, we can, and community, not just involvement, but community power and community resistance or proactivity, we can begin to define what it means, what health is not, and how we want to move forward. And I think we can do that through Circle.
Thank you, Jason. I haven't. Oh, go ahead, Ivelyse.
Oh, sorry.
In there.
Okay, I just want to just add to that, and I think Jason, you brought this up, looking at our past, and I'd be remiss not to say that like we are largely inspired by our past and the community uprising or, the community coalition to change that. And so just two great resources, or two great, moments in history, were the Black Panther Party and the Young Lord Party, who really, talk about transforming health and doing that in collaboration and upending a system, really quickly. Like the Black Panthers, right, are really responsible for beginning what we know today is the free lunch program across the US and schools. They did door-to-door lupus testing. The Young Lords did door-to-door lead testing and had like sanitation initiatives where they were sweeping garbage from the streets. And so I think those are really good. And they're also responsible for the Patient Bill of Rights that we know today in healthcare. So when we look at health and equity and transforming the system, it's been done before and had, effects now. We all benefit from that work. And so I think looking at models and methodologies that we can look to that to inspire us, but also to guide us, I think those are two great examples. Oh, you're on mute again.
Thank you. Absolutely. I'm so glad. I was actually going to ask you all about that very thing, the historical models that you're drawing from, and specifically kind of the ones that you mentioned. So I'm really, really glad that you brought that into the conversation. And for those who are, who may be guests on our webinar and hearing about this for the first time, there are a number of articles that you can find, for example, around the Black Panthers as health activists, a piece Beyond Berets. There's pieces on the Young Lords and their work, but both of those organizations noted for their contributions to public health, but oftentimes are stories that so many of us are completely unaware of. So I'm really glad that you brought that into the conversation, Ivelyse. And I think that actually is a great a point to tie into this next question. And for those of you who are guests, I just want to remind you all to please add both any questions you have, any comments, even if it's something brief that you'd like to contribute to our conversation, or ask our guests to go ahead and type that into the Q&A window. Whether you want to need to share who you are or not, you can type that into the Q&A window and I'll read it out loud to our guests. So the next question, Ivelyse, you're working in especially neighborhood-based spaces. Jason, you are working now outside of prisons, but have done the Circle of Knowledge program. It was administered in prisons with incarcerated men. This question is actually about, do you all have any ideas on how restorative justice circles application, this particular application with health justice, can be applied within higher education?
I'm happy to chat about that. So we actually have worked with folks in higher education, and this is a wonderful opportunity. When what we see is, I think there are different ways of looking at this in higher education. We found the greatest opportunity to be in research, right? So I think we can look at equity and health equity specifically for researchers who are doing their dissertations and their projects. Who often go to communities that are Black and brown and poor, do their research, kind of, exploit knowledge from the communities, and there's zero return to those spaces. And so what we found is actually the researchers and those leading that are incredibly receptive to doing circles and to using circles as a way to, one, collect, their qualitative measures, but really as a great starting point to build like a meaningful relationship that isn't just this like extraditing of information or extracting and never giving back. The other way that we've seen this too is within academia that also has some of the same structures of, white men leading and running things, but wanting to undo some of just to start talking about that. And so doing circles within staff, within researchers, as a way to begin, and then rolling that out into communities. One last thing, we're working with the university this spring, on also adding to some of their programming that they're doing. So we partner with them and we're doing circles. They have a public health program that they're initiating, but we're gonna be incorporating our circles in addition to that, to talk about health and equity in that space.
Thank you, Ivelyse. Those are excellent ideas, really great ideas and great points. Jason, do you have any thoughts to add on restorative justice approaches, our circle process approaches to health justice and equity that could be used in higher education or within the higher education context?
Yeah, I think specifically, yeah, it's really moving away, you know, from the prescriptive model. And I keep coming back to that because, I mean, that was my experience going through grad school. And I think the ways to do that are a little bit on an individual level. You have to be less susceptible to the jump through the higher hoop mentality that gets fostered in these situations, so that you are more open to either starting a circle in that context, advocating for it, or joining it. So I don't think, it's interesting. I'm always surprised in any circle I do, how surprised people are that it works and that it's a comfortable experience. And it's always like this aha at the end of it, like, that was so amazing. And I think for me, I realized that how out of the ordinary it is in our daily experience, and particularly in our spaces outside our home, like whether it be work, school, or our hospital, for instance. So yeah, you know, I did a summer youth program that was designed to give kids from the Mission area in San Francisco access to a hospital setting and some training, and just to pull back the veil of, you know, San Francisco General, which now became Zuckerberg General, right? I mean, it's amazing, and the Mission's experiencing horrendous gentrification. Many of these kids were born in that hospital, but now, you know, the idea that they could work there seems foreign, you know, and so I think that's another way that we're going to see institutions change, is by younger generations coming up through. And I think we also have to have an eye towards that, you know, we, as a member of the medical community, I need to have my eyes and ears open for other people that are bringing great ideas and great possibilities, so that I can be a part of that change. And I think keeping an eye on the next generation, that, and are there things that we're doing to bring young people up and through, and then send them off to infiltrate some of these power structures so that they can change them. I think that is also a very important piece.
Absolutely. In addition to the actual process or practice of circles, but getting more to those values and with those principles, particularly around social justice, and how do we actually have our work informed by social justice principles, including equity, who's in our classrooms, and who are we listening to? Yeah, absolutely. Two of the other things that I heard you all say that I think are relevant to this question, one is around the, again, around power. And so in the classroom, using circle process as a way of giving up power, and also of the power to define terminology. I heard you talk about that, Ivelyse, that one of the ways that you're using these circles is to define health, for example. And so I think that would be really interesting for health care educators to use that as an approach in the classroom to, for example, elicit, well, how are you defining health, and have students to participate in that as also a participatory approach to experience that, to get training on circle processes. So those are facilitated with integrity, but to use that even as a learning approach, that then their students are more likely to use those in different ways when they go out into their practice. And then the second way that Another is in terms of history. So we just talked about for community organizing models that have existed historically, the Black Panthers and the Young Lords. So bringing those examples into the classroom and teaching, again, going beyond only the circle process model, but actually sharing these examples where communities, and particularly communities of color, have really led innovative, really important breaking ways of increasing access to health equity and doing health justice work, even having conversations about health equity and health justice, which I think are really some of the other ideas I'm hearing suggested by your conversations. So another question, this question comes from Ruben from the South Bronx. You both mentioned the importance of doctors and others who traditionally hold power in healthcare systems coming into circles to listen and to learn. So the power of doctors and other providers, others who hold power. Are you seeing that happen? So are you seeing actually doctors and others who traditionally hold power in healthcare actually coming into the circles to listen and to learn? And if yes, are you seeing some transformation in them and in their relationships with those who have been defined as patients? Jason, would you like to start?
Well, yeah, thank you, Ruben. I've only been in my workplace for a month, so I can't quite rock the boat just yet. But no, I think I haven't personally seen it in my training where there have been doctors or nurse practitioners, people we tend to think of as our primary care providers, participate in these circles. There is a group out here run out of UCSF that I'm going to start attending to see what's going on, but I have not seen it translate from sort of the meeting place into the clinic. So I don't know. And that's where this is all beginning. I'm not quite sure how it's going to shape up. So it's nascent.
Thanks, Jason.
Yeah, I think, I'll say this, I've worked in other spaces, right? So in the education system, I've seen a lot of guidance counselors participating in the circle, social workers, and I think outside of health. And so earlier I talked about, right, working in housing outside of health, everyone is on it, with it, understands the value, and they want to get in as fast as they can. In the health system and with like traditional like medical professionals, what we've seen is on the institutional level, the circles actually we've done them with like residents, with med students, and some attendings, and that's actually gone pretty well. They attend a little reluctantly, and I think sometimes that's time-based, right? So for us circles, I mean, you need at least 3 hours to have like a meaningful circle, and so time is just really tight for them. There's also some legality that we're trying to overcome where you can't necessarily recruit patients from your clinic to do these circles just because of HIPAA, and sharing that becomes a real big violation. Where we've seen this happen is like folks operating outside of their 9-to-5 jobs. So we did a circle at a DACA clinic that we hosted, and those are folks who just volunteered their time. So they were mostly physicians, some social workers, and community members. And, the willingness to participate outside of those systems is there. And we're getting a lot more interest of, how can we do these? And ultimately, I think for us, our answer and our solution is like, we're not necessarily going to do this through the formal healthcare system because I don't think they're ready for it. We want to prove the model outside. Folks like Jason, right, who are coming through, and others who are in this space wanting to engage meaningfully with their community outside of that being navigated by the system.
Thank you, Ivelyse. And this next question actually builds just on what you both shared. It's kind of even a follow-on question, even though it's from someone else. So this is for both of you. I would love to know more about who facilitates these circles. And you spoke a little bit to this, but if you can talk a little bit more about who facilitates the circles, and if you think co-facilitators are useful for your work. In addition, do you have any thoughts about how medical professionals can learn to not have power over in their approach to keeping these circles, how to not be the experts? Jason, you just talked about this. This is a challenge in what you've observed so far, but do you have any thoughts about kind of the learning and how people can actually learn to sit and listen, which you both emphasize, in addition to kind of, again, thoughts on who facilitates and the use of co-facilitators?
Okay, I'll start, I guess, this time. So for us, I mean, when we started, and even still, I did a lot of the trainings, in the circles rather. I got trained in Chicago with Aura Schaub a few years ago, and so I just started doing circles. Today we have circle keepers that actually facilitate these circles, and so these are folks who live in the community in which we're doing these, or who represent the community. So we've done, you know, Bronx circles, and we'll have a Bronx circle keeper there. And we do couple that with co-facilitators. And so I think the co-facilitators are incredibly important. Actually, I think sometimes even more so important for a few reasons, especially, I mean, one, just to hold space. This is, you know, this gets really heavy and tough. Not a light one. So having a co-facilitator to help carry that is great. But also if you can have a co-facilitator that represents, especially if you have two types of parties, that is incredibly helpful as well. And so, yeah, we try to hire from the community. I said this year we're going to start training folks and doing some more circle trainings so that folks from the community can actually be equipped to host the circles and facilitate the circles. And then for the medical professionals, you know, the good thing about the circle, you know, the circle can handle anything. And the circle itself, the methodology, the practice of it, you know, all of those pieces, surprisingly, it works every single time. I often leave surprised. So the medical professionals actually, they learn in the practice of circle. I can't speak to how much of that they're taking back to their daily jobs, but we know that in circle, it does work, and hopefully models that outside of that.
Thanks, Ivelyse.
Yeah, and I just want to second that. Anytime I've co-facilitated, it's just so much better. And I shared that story about the men who were lifers in prison who in my mind became co-facilitators. You know, they didn't necessarily go through any training or whatever, but they held the circle, they held the values, and they partnered with me and held the space. So that co-facilitation is huge. And I think in terms of school and education and what can be done, that's a big question. There's, you know, people go into hundreds of thousands of dollars of debt to go to these schools, and they come out, and, you know, oftentimes it's like, I got to deal with this debt. If you're a doctor, it's been 8 to 10 years of your life. For me, it was 3. Well, probably a little more given, but I think, you know, one of the movements is to move away from grades. And as simple as that sounds, and maybe as maybe not meaningful in given some of the things that we're talking about and the severity of it, it is a small shift in the mindset of why you are going to school. Because I think too many times individuals in these settings are really just worried about themselves, and that gets re-emphasized through the school process. It is a war of attrition. You just survive to the end, and by the time you get to the end of it, you really become very focused on your own needs. And that does not translate well as into being a healthcare provider, you know? And that's why we do see people, we see doctors no longer becoming primary care providers because they can't get paid at the end of it. They're becoming specialists that, and our whole system is now shifting towards a referral mechanism to specialists because those are the most profitable jobs. So public health is not profitable. That's another, you know, issue. It keeps people from pursuing public health positions. But I think on just that educational piece, and you need professors and people who build curriculums to understand and value the importance of relationships, so that it becomes part of the classroom setting.
Thank you, Jason. Wow, I found that to be what you just said to be such a profound insight in terms of just thinking about formation and training and how do we, you know, do formation and training differently. I think oftentimes that conversation happens in many other fields. How are police officers formed and trained? How are guards at prisons? And sometimes we miss the insight that you made in terms of healthcare and the relationship between the individual, what you talked about, individuality, and how that can be such a part of so much of our formation. I'm meaning our in terms of collective societally, but in terms of what you're specifically talking about, medical professionals. I found that to be really important. Thank you. So 2 more questions as we wrap up, and we'll see if we can get to both of these in the next 5 minutes. Actually read them together since we need to wrap up in just a few minutes. But Jason, one piece that jumped out for this guest, Kai from Vermont, is earlier when you were talking about the group medical visits, and particularly one of the points about the confidentiality, which you mentioned, Ivelyse. So you, Jason, mentioned the issue of billing as being a stumbling block to more widespread adoption, but how do you address the issue of HIPAA and confidentiality in the context of a group setting, or the group medical visit? So that's one question. The other question is quite different. And this question is from Victoria, who asked an earlier question. This one is about reentry and reintegration. Reentry and reintegration, restorative justice practices that are used in reentry and reintegration are instrumental to focus not just on individual harms and needs, but can also address structural or historical harms. What kind of buy-in is needed to have more of restorative justice reintegration practices around reentry for health justice initiatives? Most of the work is left to nonprofits who often have RJ staff, but are not finding the funding to do that kind of work. And so maybe Ivelyse, you can especially speak to that question. And Jason, you could speak to this one around the group medical visits that you're thinking through and involved with.
I think ultimately, you know, HIPAA is there as a form of protection. I certainly haven't read the whole thing. But, you know, the circle is going to do what the circle does. And if we come together and one of our values is confidentiality, there's no HIPAA declaration that is going to convince a person to honor that. You know, the honoring of that value is going to come from the group and a person's degree of respect for that group. So I feel that when you bring people together, when we come together, there's always the possibility that there's going to be something that goes off track, and that we build systems to try and prevent against that, but then we become beholden to those systems, and that's where I think we've arrived at. So I don't have an answer other than if the circle says that this is what we're doing, then I expect everybody in that circle and everybody else in that circle expects that to happen. So we hold each other accountable.
Thank you, Jason.
Great. Yeah, and I guess I can take the next question, which was, so how do we, I'm looking at it now, how do we approach RJ and reintegration? So, I mean, I think, right, the buy-in is tough. Personally, I don't know that we can look to like health systems to talk about, you know, reintegration and reentry programs and the health job. well, we can. And I think, right, the buy-in has to be, these are the cost savings if we want to play in the same, if we want to play the same game that's being played right now, right? And so some of the stuff that we're talking about is like when we have like actual, I mean, reentry programs, we know that they're effective, right? But when we talk about that on a health space, like, can we save money, right? So that, does this mean that this person is not going to end up in the emergency room where an average visit is about $3,000? But in lieu of that, we'll actually see maybe a primary care physician or go to a group, medical home. And so we just need to, and this becomes like taking the work and applying like a financial business model, I guess, to it. But when we can start to get buy-in and show that, like, not only is this going to have like profound like improvements on this individual's life, but you'll actually health system or payer, you'll actually save money. I think that's when we'll start to see this create some more traction and see some traction there. In terms of the RJ staff, right, and those who, or nonprofits that have RJ staff but have a hard time finding the funding, I mean, I'm a firm believer in that, like, this is where, at least for us, our model has been to work outside of the system, to operate and work with folks who are not necessarily in health, to get started. And so that's where we've worked with, the housing agencies, education, and kind of gone around the circle. But I think this is a perfect opportunity, right, for nonprofits who are doing justice work to engage with the healthcare system and tap into, I mean, the US spends $3 trillion a year on unnecessary medical visits, $3 trillion every single year. I can guarantee you, your local hospital, they have to do a community needs assessment, and that's how they maintain their nonprofit status. And in that, they have to do community benefits and do stuff that's for the community. I would encourage you, if you know nonprofits, if you're an RJ facilitator and you want to do circles and you can do them in a health thing, to speak to your local hospital, speak to an insurance provider, speak to anyone that is playing in this $3 trillion space. We can find, I believe in abundance as well. Like, there is an abundance of money in healthcare that can help support that and create longevity and additional forms of impact.
Thank you, Ivelyse. Well said. Thank you so much. And thank you also to our guests for those excellent questions. And to those of you joining us, really great questions and comments. Thank you so much for contributing those. And we ask that you stay for just a few more minutes as we wrap up our really amazing webinar today. What a conversation that we've had. Thank you so much, Ivelyse. Thank you so much, Jason, for the presentations, for this conversation. One thing I just encourage, one of the things that I also am really excited about our work at the Zehr Institute is connection. So for those of you who have joined us and are seeking to do this work or already engaged in it, one way that you can get connected to Ivelyse is visit the website of Radical Health. One way I would say to get connected to our presenters for today in terms of just networking, you can email us at the Zehr Institute, zehr-institute.org. You can go to our website, contact us, and we can put you in contact with our presenters for those who are really interested in talking with them more and building around these issues. Thank you again. And with that, I'll go to Julian. Thank you so much. I'll go to our graduate assistant, Julian Ward, who'll give us some very important announcements about what's coming up next with the Zehr Institute. So please stay posted for that too.
Okay, thanks, Johonna. We have one upcoming webinar for the rest of the spring semester. It's April 17th, Love and Living Soil, Restoring Justice for Land and Community. That's with local Harrisonburg resident Jonathan McCrae. And we have STAR trainings, that's Strategies for Trauma Awareness and Resilience. STAR is a research-based training program that brings together theory and practices from neurobiology, conflict transformation, human security, spirituality, and restorative justice to address the needs of trauma-impacted individuals and communities. This program is designed for individuals and organizations whose work bring them into contact with populations dealing with current or historic trauma. Visit the website on the screen if you'd like to know more. We also offer a graduate certificate in restorative justice. The certificate is 18 credit hours with equal focus given to conflict analysis and practice, restorative justice studies, and electives which could focus on monitoring evaluation and psychosocial trauma. The certificate can be completed through a number of courses offered through the annual Summer Peacebuilding Institute or through a combination of 1 semester on campus and 1 summer term. We also offer a RJ in education for those interested in the intersections of education and restorative justice, and a 15-hour graduate certificate in RJ in education, which can be used by a variety of professionals working in educational settings. There are also 2 master's degrees, one in a master's in conflict transformation and another in restorative justice. The curriculum is practice-based and ideal for individuals looking to be reflective practitioners within their chosen field. And finally, visit our website for past webinars, upcoming events, publications, and you can find the link for this webinar within the next couple days on the site. Thank you. Back to Johonna.
Thank you, Julian, for those announcements. In closing, I want to thank our incredible presenters once again for sharing about the work that you're doing that is truly innovative at the intersections of restorative justice and health justice. Our next, and I also want to mention that our next webinar has a similar focus on intersections. We'll be talking about the intersections of restorative justice and environmental justice for that one. And so we're continually doing this work around looking at intersections of restorative justice with other areas and cutting edge work. Our presenters today really enabled us to do that in a deeper way, and I learned a lot, and I know our participants did as well. So thank you once again, Ivelyse and Jason.
No, thank you, Johonna. Really a pleasure.
And with that, we will close for our webinar for today. And I wish everyone a wonderful rest of the week, and also many much excitement on the inspiration that you've heard and what you'll be doing with that in your work, on your journey. Thanks once again. And goodbye.